Welcome back, everyone, to another edition of the Disruptive Dental Science podcast, brought to you by Dental Advisor. My name is Dr. Ashton Prince. I am one of the clinical ambassadors for Dental Advisor, and I am absolutely thrilled to be joined by a couple of colleagues and fellow ambassadors for Dental Advisor as well. We have both Dr. Paresh Shah and we have Dr. Taiseer Sulaiman. Now, gentlemen, it's a pleasure to have you. Thanks for joining me.
Great to be
Always
here.
a
Thanks
pleasure.
very much,
Great to be
Ashton.
here. Absolutely.
Wow.
Pleasure.
So the beautiful part about this is that when I personally am going through certain situations, I've got certain procedures and things that are in my office, and I'm not quite sure with all of the developments and things that are going on, the advancements that happen in dentistry. I always am trying to find out how are those that I look up to, those that I actually respect highly because of what I've seen them do, what I know that their educational basis has been. In all generalities of things, I look for answers to try and make sure that I am doing things in the best fashion for my own patients as well. Taiseer, I'm going to go to you first on this one.
Yeah.
Because the topic that I kind of want to bring up, at least for tonight, is we've got so many different blocks. We've got so many different ideas when it comes to ceramics, glass ceramics, zirconia. We now have these hybrid blocks that are coming out with things. Are you seeing this as a good thing to have so many options, or are we starting to muddy the water just a little bit too much?
I think the latter. It becomes concerning when clinicians write to their laboratory technician, please make a ceramic crown. Okay. And then, or please make a zirconia crown without specifying. And so that always puzzled me. Are you not specifying because you don't know? Or you trust your technician 100%, which of course we love our technicians. We can't do this without them.
Sure.
But I believe that mechanical and optical properties of every indirect restorative material that is available to us must be of our knowledge so that we can direct our technician in a healthy conversation, okay, about what we're looking for, because we are the ones that are responsible in front of the patient about the final outcome, whether it's aesthetics, whether it's resistance to fracture and occlusal loads.
Sure.
So if you need to restore a heavy load-bearing area, you have to know the mechanical properties of these different materials, and they're not all the same. If you need to restore a single central incisor in the aesthetic zone, you need to know their optical qualities, because again, they're not the same. Are you restoring a dark underlying structure, whether it's a titanium abutment or a cast post? You need to understand, if you want to go through the ceramics route, what ceramic can provide you with a level of opacity that can mask that dark underlying structure. Makes sense. That's not all the same. And so if just a simple example, if you have a cast post, let's say, or a titanium abutment on a central incisor that you're trying to restore, you write to your laboratory technician, please make a zirconia crown. Most likely you will get some of the cubic stuff, which is the more recent stuff. And the translucency of the cubic zirconia, or the 5Y zirconia, is higher, right? It's more translucent than the 3Y conventional zirconia.
Sure.
It will not have the ability to mask dark underlying structure, however talented that technician is going to be, period. And so, and so that's the challenge, right? So you have to know, wait a minute, I have a dark underlying structure. I need to use a 3Y zirconia that can mask dark underlying structure with enough thickness also, and then layer the facial for aesthetics and characterization. So you see how it gets very confusing. So all these different types of blocks that we have, if you're a digital dentist in this modern era, and you open that drawer, you can have tens of different blocks available to you. And I think that's way, way too many.
Paresh, let's hear from you. What are your thoughts here, buddy?
Yeah, no, I totally agree. There, from a CAD/CAM in office point of view, like, are you choosing the materials because it's on sale? There's a deal. No, I mean, this is the reality.
No,
you're running a business, right? Or are you actually choosing appropriate materials to accomplish some of the restorative that you're doing, whether it's, inlays, onlays, or aesthetic work, and so forth. So it's having so many materials. It's a nice luxury to have as a restorative doc, but it also is daunting because there's so many options. And sometimes you just start looking, hey, what do I pick? But I agree with Taiseer. Like I've always said, we should, and I actually have a lecture title called Before We Pick Up the Burr. But I really feel it's important that we, before we actually pick up a burr and prep a tooth, we should at least have a general idea of what that outcome is going to, that we want.
What you need. Sure. Yep.
Right.
Absolutely.
Like whether the margin is showing or not, whether you can actually cement it because it's 5 millimeters subgingival, like just pick that and the function. And from there, I'll have a conversation with my ceramist after, because Taiseer, you'd agree, like some ceramists are more comfortable using a material for aesthetic purposes.
Yep. Very
Some of them
true.
are better with zirconia, some of them are better with metal, some of them are better with lithium disilicate.
Absolutely.
And so
Absolutely.
also getting their input after, hey, these are the goals. This is what the photography looks like. This is what we're trying to accomplish. So yeah, it's like but it's us restorative docs that should be thinking about this before we prep a tooth.
Before you pick up the burr itself. So
Right.
I've done the same thing in my own practice where I'm looking to see what are my adjacent teeth? What am I trying to blend into? What do I need to block out? Like Taiseer said just a moment ago. You start to go through the entire process of figuring out this is what I need out of this restoration. And then you start working your way backwards. Now, what's the color going to be? What's the substrate going to be? What am I blocking out? And you get all the way back to it. And then you pray and you hope that you have the right block color or the right material that you're hoping for. Because if not,
Right.
well, now we're temporizing things. But in the digital aspect of things where everybody is so concerned about how quickly can this be done, you know, the ways that these blocks are going now, it's getting to a point where now the sintering process is a little faster. I mean, you take the Katana 1 speed blocks that they've actually got for these Zirconia blocks that are out there. They're fantastic. I mean, you mill these things out in about 8-9 minutes. It's sintering in 9, and you've got yourself a Zirconia crown ready to go. Now, granted, we're not going into the cubic aspects. I mean, you're still fairly opaque with what these materials are, but they turn out beautiful if that's what you actually need out of these things. But there's so many of them that are coming out now that are, I would dare say, concerning. But I'm going to ask you a question. I did not, and here's the kick for everybody that's listening to this. When you get the three of us together, the conversation starts to go way off path real quick. But I'm going to ask something that I did not prep these guys for, so I'm curious as whether or not they actually have an answer for me on this one. But my question is, how strong do we need our restorations to be? Do we need them to be the same as enamel, the same as dentin? Do we need the strength of zirconia all the time so we get that functionality out of it? I'm going to go to you first, Paresh, because I want to hear your answer on this one.
You know,
how strong?
I try and base it on the individual, depending on the person, the type of wear they may or may not have, the size, the patient as well, all of those things, and what I'm trying to accomplish. So it really does vary, but I typically, like if I've got a really heavier individual with a lot of destruction and wear in the posteriors, I'm leaning towards at least a 4Y and sometimes a 5Y zirconia in that area. I know that there's a lot of people out there that'll just say, okay, well, you can still do it with e.max and you can bond there and we know it's predictable and as long as you balance the occlusion. But I'm still a little concerned about it. So I tend to err towards some form of zirconia and even not a translucent one, but probably a 4Y. But if it's a younger or a person not as big, not as much wear, and you're trying to maybe open vertical and things like that, I'll use e.max. I'll bond it in there. I'll make sure that I don't follow I try not to go to the bare minimum. I try and go fit within the higher end of minimum standards for what the manufacturer prescribes.
You're talking reduction, a little bit over. Okay.
Or the size of the restoration.
Gotcha.
Yeah, because if it's additive, then I'm adding, but I don't want to, I'm not going to do e.max at 9/10 of a millimeter. It's, you can probably get away with it.
Yeah. Fracture. You'll have some fun with it later.
So from a strength point of view, it is an individual thing. And part of it does come with experience. If you're a young dentist, you haven't had enough experience to try these things. I mean, I got the days of, you probably have it as well. You've got a lot of gold onlays and gold crowns, but after 35 years, they're worn through.
Yeah.
Yeah.
Yeah. Taiseer, let's hear your opinion on this.
Well, I think that's a wonderful question because it's going to allow me to share a concern that I have, and I hope
hear
I'm
it.
wrong with this concern. Okay. And because you asked, how strong or how do we really need these ceramics to be? And this stems from your knowledge about the mechanical properties of the tooth structure. And this is something I never knew. I had to go and dig that information out. But they've tested flexural strength of enamel, fracture toughness of enamel and dentin, elastic modulus, the rigidity of the material. And if you look at those properties, those are three very clinically relevant properties. You look at flexural strength of enamels around 1,000 megapascal, dentin is around 200. Fracture toughness of enamel is around 1.2, which is the resistance to crack propagation. And that's a very important property because that's how ceramics fail, through crack propagation. And the elastic modulus, enamel is the highest, can reach up to 90, maximum 100 gigapascals. And that's how rigid that material is. Now, if you look at the glass ceramics, a lot of them fall within the same mechanical properties, similar mechanical properties to the tooth structure. And the closest, perhaps, is lithium disilicate as a glass ceramic material because it has the structure reinforcement better than feldspathic. So now we can use it, like Paresh was talking about, as a full crown, as a partial coverage crown, as a veneer, very comfortably because of its enhanced strength compared to a glass ceramic. So those are okay, and sometimes you want properties that are, again, similar to the tooth structure, because if you have properties that exceed the tooth structure, you're already crossing out any belief of biomimetics.
Right.
If you ever go down that area, if you are a biomimetic dentist, let's say you follow the principles of biomimetic dentistry, zirconia should not exist in your in your arsenal of materials. Period. It has nothing to do with the tooth structure in terms of it's stronger, it's harder, it doesn't wear. When it's highly polished, it doesn't wear the opposing. So now the concern comes from, wait a minute, the rigidity of a tooth structure, enamel being the highest, is 80 to 100 gigapascals.
Yeah.
Zirconia is 205.
Right.
So when you have a bruxing patient that's biting down heavily on that crown, where the force is going? I mean, it doesn't absorb these forces. It's a very hard material. And so I can only think about what's happening to the periodontal ligament over time with fatigue.
Gotcha.
And
I got to start questioning some of that stuff.
This
is a great conversation.
So you got to wonder where the forces are going. Now, what led me to really ask these questions, we don't have long-term clinical follow-ups on these crowns. We don't know. Osseointegrated implants, we have no idea where the forces are going. These are all zirconia prostheses that they're making. Again, because of this hardness, it's not absorbing. If you bite down hard on a natural tooth structure, it will break, right? On an unwanted object in your mouth, it will break. That's just the nature. Then that's a God-given kind of blessing that you don't want to damage, everything along your, the supporting structure of the tooth, so the crown can fracture or chip off. Glass ceramics will do the same thing. Lithium disilicate, you bite on it too hard, it will break. It's a shock absorbing action. Raises awareness that, wait a minute, I bit on something hard and I need to take it easier. I need to stop. But with zirconia, you keep biting, it feels like you're not doing anything, and you bite harder and harder. All the forces are going to the periodontal ligament, osseointegrated implant surface. You speak to endodontist, they ask you, how do I drill through these crowns? So you ask yourself, wait a minute, monolithic zirconia has been around for 15 years. So already you're talking about biological success.
Yeah.
And this is something that the only way we are able to properly analyze this is that we have a long-term study that you follow up over time. We might not see fracture, we might not see debonding, we might not see change in color, all factors that are phenomenal for an indirect restorative material. But biological success is a big question mark.
It is.
If you start to see access hole through these crowns, no, that's a failure. It's a failure through periodontal ligament inflammation, then infection, and then you have trauma from occlusion. You speak to surgeons, they're pulling out these crowns with fractured roots. I've had some surgeons bring that to my attention, said, listen, I'm pulling out this crown. It just looks like a zirconia crown, but it's most likely it is, because 90% of our work right now is all zirconia, right? And so again, my concern is the hardness. And is it too hard of a material? Absolutely, it is. How is it translating to the biological success of tooth-supported and implant-supported prosthesis? I don't know. It's a theory that I have. I'm going to try to test it somehow, but I hope I am wrong. And there's no issue whatsoever, because we have put thousands of these in the patient's mouth.
Absolutely. You know what? It's interesting you say that, and it would be nice to know. And hopefully we find that during my career, so you can pivot or adapt to certain things.
It's just like anything that we've used in the past that we thought,
right?
A PFM, you put that on the lingual side, that'll protect things. You can keep it nice and thin. What was that doing to the opposing arch? For a lot of people, a lot of situations, it was more detrimental than it actually was a benefit. But with zirconia being such a highlight to what we're using, and I've dealt with a lot of dentists that just have it in their mindset of, I just want it to be as strong as I can get it because I don't want this thing to fracture. Well, that's great. Your crown usually isn't the thing that fails. Usually it is the supporting tooth structure underneath. It's that foundation that's there, that if you're beating that way too hard with things because you haven't thought through the entire biological process, and beautifully said with all that, Taiseer, that was well said. If you're not going through that entire mentality, this is not just what does the tooth look like? What do I need to restore this back to? This actually needs to go through a process of what does the mouth need more so than anything else. So I'll ask and kind of transition here for a second. We've got zirconia, we've got lithium disilicates. What about these nanohybrid composite blocks and things like that that are actually coming out? I mean, you've got your GC Cerismarts, your Vita e.max, your Voco Grandio blocks. Have you played with these very much at all?
Yeah, I've used like Cerismart, and I've used like some of the Voco Grandioso blocks in my practice for some, direct restorative materials.
And what are your thoughts with them? I mean, when you're using them in certain times.
I like the handling of them. I've done them sometimes where I've wanted to, patients wanted some veneers and some onlays, things like that, and they've worked out well. I like the handling and the polishing and everything, but I don't know about the long term. I mean, I'm assuming that as long as I'm looking after the occlusion as best as I can and managing to put it in a system that's not wonky, can I say, that I'm comfortable that it can last a reasonable amount of time.
Well, that's a beautiful side point to it anyway. It doesn't matter what the material is that you're using. If you don't have your occlusion in the right spot, you're going to beat the snot out of something anyway.
Yeah, absolutely. It's just important to be realistic and let the patients know about that as well.
Yeah. Taiseer, what are your thoughts on these blocks? Or this material? Let's just call the material.
I don't want to sound harsh about giving a strong opinion, because I want to first recognize the effort that manufacturers and researchers put in developing products like this. It's phenomenal. I mean, it really is unbelievable. What they're trying to do, of course, is provide service, whether it's for the clinician or for the patient. And so, when you have, it's very important to distinguish between a hybrid ceramic, which is mostly a ceramic mesh infiltrated with resin, something like Vita e.max, and between an actual composite block, which is a resin that has filler particles in it for reinforcement, like Lava Ultimate. Okay, so those are two important distinctions to make, because it has it influences properties and it influences bonding protocols as well. And so when I look at this is part of a big debate of ceramics versus composites, right? And these kind of scenarios. There are times, maybe because of cost, or maybe because of how fast you need to do things, that you can actually mill a composite block and with beautiful anatomy and use it as a restoration. My concern is what you're providing your patient in terms of long-term and durability. and what you're guaranteeing for your patient or not. I mean, it's just like Paresh was mentioning, we don't know how these things are performed. We have some information on them that if you look at, for example, Dynamic, 3 years, there's a 5-year follow-up study where you can see that, debonding was
Mhm.
a problem, change in color, and wear resistance. And so wear is usually overlooked in a lot of these evaluations as well. In addition to the biological success, wear is a problem because, you natural teeth wear at a normal rate. It's about 25 to 30 microns over a year. And you want your material to follow that same pattern. So for zirconia, it's going to stand tall. It's not going to wear.
Right.
And that's a problem. That's how it can change the occlusion over time. But, you have these type of materials, again, while I appreciate the effort behind them, because of their resin content, you can't help but recall the deficiencies that resin material have, and that
Sure.
is susceptibility to wear and color stability. And you increase resin in a indirect restoration, you're increasing its flexibility as well, and that also leads to debonding because of you with that flexing and that fatiguing, you're breaking that cement bond to the tooth structure as well. So these are concerns that you might necessarily have as much with glass ceramics and zirconia, but pertinent to these resin-based blocks, because of the resin content, however low it is, you can't help but wonder how is it going to wear and how color stable it is going to be and how well it's going to bond.
Sure.
And early studies that are showing on some of these materials, they're not as promising as we've seen with specifically when I say glass ceramics, lithium disilicate.
Yeah. So it's fair to say that you get a little bit more of a comfort zone based in these glass ceramics for yourself, correct? If you're setting up your patients the correct way, your occlusion's correct, they're not bruxing into things too terribly hard, you find a lot of comfort in these glass ceramics. Is that accurate?
Yes, specifically lithium disilicate. And yeah, I think you brought a point up that was very interesting about speed of producing these things
Mm-hmm.
and how it's advanced over the years. And again, appreciate all the research and technology and advancements and manufacturers putting in an effort to minimize the clinician's time. This might sound again a little mean, but what we have seen in the literature so far that again, these are material scientists reporting these things. It's not my reporting. I'm just regurgitating this information that easier is not always better.
Sure.
Okay. And sometimes things require time. So in other words, when you have a fully crystallized block
Mm-hmm.
that you're milling, and the point is that you are saving time with crystallization or sintering, whatever you want to call it. And so you design, you mill, finish, and polish and bond. So you save that 15, 18 minutes, however that crystallization time is. Some clinicians, that's valuable time to them, right?
Sure.
If so, the conclusion from my good friend Yu Zhang from UPenn on lithium-based ceramics, pre-crystallized versus fully crystallized blocks. Anytime you have a pre-crystallized block that requires heat treatment is always better in strength and other mechanical properties compared to fully crystallized that does not require heat treatment.
Interesting.
And if you think about it, the fully crystallized, it's fully crystallized. You're milling into it. What are you introducing while you're milling?
You're talking fracture rates.
Yeah, micro cracks. You're
Yes.
introducing all these defects on the surface. And so the crystallization process delineates and removes a lot of these defects. That's why you get better strength and better mechanical properties versus a fully crystallized one. You mill, you introduce these micro cracks, and then you put it in the patient's mouth. And now it's just a ticking bomb now, right? And so well, Paresh brought up a great point by saying, are we actually with all these blocks, are we saving any money? Actually, sometimes you're paying more.
Sure.
And with inferior in vitro studies compared to lithium disilicate, and with no clinical trials compared to lithium disilicate. So I might sound biased towards lithium disilicate,
Yeah.
but it's just because we have now wealth of information since its presence since 2004, 2005. And I wish we can say the same for a lot of these more lithium-based ceramics we don't have any information on.
It's interesting because we don't know what's going to be coming up once we get studies in the next 10 to 15 years, and then I remember going through stages early in my career. I don't know if I can mention products, but there's been a couple of
Go
crown
ahead.
products. Well, you remember Concept and you
Oh, yes,
remember
absolutely.
Target Spectrus, and 10 years later, I was replacing all of them.
Yeah.
We got 10 years out of it, but the reality, and they're off the market right now. I mean, you learn through that, right? And I think, to Zir's point, part of this is trying to be as intentional and thoughtful as possible when we're doing our work, because for some of these products, we're testing it. We're testing them out, right? And even though we have Health Canada or FDA approval, some of them we're testing out.
There's nothing greater than when I hear a rep coming through and saying, this is the last block you're ever going to need. This is the last material. This is going to last forever. This is the golden standard. Nothing will ever replace this. We are constantly improving so much that I actually am going to ask that as my next question. If you could build the perfect material, and I think I've already heard what Taiseer's preference is, it's going to be lithium disilicate right out of the gate. But if you could create your perfect material, what would it entail?
I'd say some sort of a highly aesthetic glass ceramic that has great strength and wear, just keep it simple, that you can bond, but you can also cement if you want to, and you're not going to compromise, the quality by doing either.
Sure. Makes sense. Taiseer, what about for you?
No, absolutely. I mean, again, based off of our knowledge from the properties of the two structure, you have mechanical and optical. You want your material to perform very similar to that, right? So you can use it very diverse. You can use it, in the aesthetic zone because of its translucency that can mimic. And, we're not all patients walk into the practice having the ability to do a full mouth rehabilitation or full smile or aesthetic rehabilitation. Sometimes you need to do that one or two, tooth in the aesthetic zone that mimics an adjacent tooth structure. And so the diversity of having a glass ceramic material that's reinforced in its strength, that has good optical properties, that you can predictably bond to the tooth structure. And if you wanted more characterization, cut it back and layer it with porcelain. I mean, it's very diverse, right? You can go monolithic, you can go layered. I mean, all of these, I think, again, learning more and more about, and I don't want to be very specific to a brand. Lithium disilicate there's multiple patent expired on Ivoclar. So there are multiple other companies that are producing lithium disilicate ceramics. It's just that Ivoclar's e.max system has the longest track record and clinical history through the Malamute studies. And if you look at them, they're quite remarkable in terms of success and survival. And now we are a little bit more we did a retrospective study by surveying laboratories about fracture rates. We published that back in 2020. And we looked at thousands of lithium disilicate and 3Y zirconias. And we asked the lab, how many of them were sent back to you because of fracture? And this is indicative of property of a material, right? Because fit and color or shade is more a technical problem, but fracture is indicative, and it's a bell curve, right? Of all the cases that they get. So it's not a controlled clinical trial, which can have high levels of bias to it because everything is ideal. You have a master clinician that selected the case very carefully under this wonderful environment and took 2-3 hours to do that beautiful prep with paper, etc. So all that is possible when you're doing a clinical trial. You translate that into a 10-minute preparation in real world dentistry, and the outcome might not apply. So that's very important when we love to see clinical trials. We rely on them in terms of evidence, but clinical trials are always prepared in perfect, ideal clinical settings, which is very rare that you'll have a setting like this in private practice. And so when we do these laboratory surveys, it takes into consideration the good, the bad, and the ugly, right? And so it really indicated a low fracture rate. Lithium disilicate and 3Y zirconia also indicated a low fracture rate. And so we started to learn from laboratory. We can learn from laboratories before we see that in evidence in the literature. Because if I wanted to, if you asked me, well, why don't you do a clinical trial on X material, okay? And you want ceramics indirect, you want a 5-year outcome, minimally. It'll take me about 8 years
Sure.
to develop a manuscript of a 5-year follow-up. So you tell me what manufacturer is going to wait and fund a study for 8 years? And it's a shame they're not,
Yeah.
because the golden studies that we have on adhesives and cements and composites are the ones that the company stuck with a long-term follow-up, and we're capable of standing on a stage and talking about it and showing that clinical evidence. But it's just a different world we live in. Just like Paresh said, manufacturer produces. Rep walks into your practice, gives it to you. If you're one of those early adapters that really just sees a free product, I'm going to try it on the patient, and then you report whatever outcome to the sales rep, and then they go back to the manufacturer to tweak it or not, and then the whole scientific clinical research community is just excluded from this whole formula.
Yeah, Paresh, I absolutely love how it is that you said that we're the guinea pigs, we're the ones trialing these materials out for people. And that makes, to see the way you put that, that makes perfect sense, that we become their versions of doing their trials for them. But I will say this, for any of these materials, for those that are listening in, you can follow the IFUs. You can see what your reduction needs to be. You can follow the processes. You can see what these materials actually need after you've actually researched into what you need the material to be for you. If we're going for the biologic aspect, if we're going for how it's going to adapt to the adjacent teeth, the substrate exactly, anything that's going to be around it that you're kind of looking into to say, this is what I need this to be. Any of us can do that if we take the time, take a deep breath and say, what do I need out of this? As opposed to just saying, there's a block in my drawer, I'm just going to use that. Let's see how it goes and go from there. If you take the time to actually think this material through, I think you can find success in the vast majority of these materials. Now, I can see the exact opposite of that as well, that you may just throw something in and hope for the best, and you haven't prepped it the right way, or you haven't done things the right way. You're going to get failures out of these. So again, for those that are listening in, then the dynamic out of this entire situation is know what you're doing, know what you're using, do some research into it. Hopefully, as Taiseer said, then you've got materials that have a track record that you can actually follow with as well, to know that you can build some confidence within these materials as well. Because once you've got the confidence there and you know what you're doing, you're going to find success in any of this.
I find one thing which I've avoided for many, many years, because I learned the hard way, especially early in the career. And again, this to Taiseer's point about not being disrespectful about how, because I appreciate all the companies putting their money into development and new products, but there's sometimes a disconnect between what's going on the bench when they're developing the product and how they're marketed.
Yeah.
And to have someone just come in with a marketing brochure, it just doesn't work for me. Like, you've got to ask a few questions. There has to be at least a few critical questions that will, without looking at the graph on the marketing brochure. And I bet you, Taiseer, would be cautious about how you approach that, because it's not, because those brochures are not always the real science.
Sure.
Because you can pick data. You can pick data, do that. And
it's only the good stuff that makes it anyway. You're leaving the bad stuff out.
It's only the good stuff, right. And so part of this whole thing is, just like you were saying, Ashton, like if something doesn't work out, just the first thing you should really look at is don't blame the product right away. Like, look back and
in the mirror.
What did I have in control of? Like, all the parameters. Did I prep properly? Did I have the right substrate? Did I do this? Did I do that? If I've done that, then fine. Look at the product or look at the ceramics. But because a lot of times we cut corners, and you're busy. Like Taiseer said, look, we're busy. It's not an ideal situation. You're prepping a tooth. You got 2 hygienists waiting, and you're close to the pulp, and you can see the red. It can be a stressful time for some people.
Sure.
And then all of a sudden you decide, and you deviate, and you make a different decision. So
Taiseer, I'm going to give you a minute to give me your best rendition now of lithium disilicates or any of the glass ceramics themselves. What final push do you want to make for the material itself?
Look, I'm not an early adapter, so I really rely on good evidence before
Sure.
making the decision. I think if you're matching teeth in the aesthetic zone, you want to go with a glass ceramic material that you can successfully bond to enamel using a light cure resin cement, because of the cement's color stability is very important. Nothing that says dual cure on it. Okay. If you're restoring in the premolar area, and you need aesthetics, you can just layer the facial. Keep the occlusal or any functional surface in monolithic ceramic or in metal if you're using a metal base. We don't need feldspathic layering on any functional surface, period. I haven't layered a functional surface in the last 10 years with feldspathic porcelain. It chips, it wears the opposing, it butchers the opposing. It's the most aggressive porcelain we have available. So highly polished monolithic lithium disilicate or monolithic zirconia or metal. These are the most friendly. And of course, zirconia and metal are the most friendly. Then comes lithium disilicate. But again, highly polished, just layer the facial for aesthetics. Premolar, I think lithium disilicate is fantastic. 4Y zirconia works very nicely in this area. And then in the posterior, you need strength. You need strength out of your restoration. So 3Y zirconia is going to be your option. Do you need any layering on the facial? Probably not. You're not going to see anything there. Ask your technician to highly polish the surface first, and then they can glaze all they want, because they love to glaze to give it that natural looking appearance. But we know the glaze will wear off, and glaze I'm glad it wears off very quick, because it's abrasive to the opposing. Yeah. So just say after, when that glazed surface is removed, you have a highly polished surface underneath that's going to be very friendly to the opposing. And if you are, again, Zurich doctor, that you have, you want to maximize the use of your milling machine, you have lithium disilicate blocks, you can use it on a posterior tooth, but you need more thickness from that ceramic. So maybe a 1.5, sometimes to 2 millimeter reduction is required, so that you can have enough thickness to avoid fracture.
Yeah. And make sure that you're polishing.
Yes, and then if you have a fixed dental prosthesis, 3-unit, 4-unit, you can go with 3Y zirconia. Why would you test any other Ys, right? You need strength. You need good connector dimensions. And the posterior 9 millimeter square is the ideal. So it's going to kind of look a heavy embrasure, but it can work up to 5 units using 3Y zirconia. And in the anterior, you can just layer the facial, keep the lingual and incisal in monolithic, and that should be the best bet for you.
Yeah. Why would you use anything besides the 3? Because you live on the edge. That you just want to see.
Yeah.
Just how far can I push this before it actually snaps on me?
Yes.
So I heard you say just a second ago that you would not use a dual curing material. You only use a light cure material. Can you tell me why?
So a thin ceramic, less than 1 millimeter in thickness. If you have a ceramic that's less than 1 millimeter in thickness in the aesthetic zone, I would pull out a light cure resin cement, because I need that cement to be color stable. Dual cure cements that have tertiary amines in them change color over time. So if it's a thin ceramic, less than 1 millimeter, it will show through your ceramic in the aesthetic zone. If it's thicker than 1 millimeters or not in the aesthetic zone, then you can use the dual cure, because it won't matter. You can't see through it.
Now, I've heard that for these lithium disilicates, up to 2 millimeters maximum is how far you can get that light to actually cure the material if you're using a light cure. Is that accurate?
Attenuation of light. We can go on and talking about all these clinical issues,
different
right?
Time,
that's wonderful.
Different time.
But you're absolutely right. Well, all the things that we talked about don't matter if you don't cure that resin properly. It will debond. And then what do? We blame the material. Like, give me another cement. This cement doesn't work. It's not the cement's fault. So light attenuation is a problem. My only recommendation here is to double your curing time, because you want to deliver enough energy to your resin. Energy equals irradiance multiplied by the time. You increase the time, you're increasing the energy. So even if you have a low performing curing light, which I hope you don't, but let's say it gives you 500-600 milliwatts.
That's another topic.
Of output,
I was going to say,
right? We can talk about light cure, right? 500-600 milliwatt per centimeter square. You cure for 20 seconds, for example, it can give you X amount of energy. You cure for 40 seconds, it can double that amount of energy. So double your curing time. hold the air syringe at the tip of those LED curing lights, because they do raise in temperature very quickly.
I think I'm going to make his brain blow up here for just a second,
Yeah.
Paresh. Watch this. So all I want is a yes or no answer to this. Can you over cure a material?
No.
Okay, done.
Yeah,
That's for a
there's no
different topic
overcuring
then.
of resin.
Yeah.
But you can
Okay.
you can grill the pulp and the
Yeah,
tissue
that's a different.
if you
Oh,
so you got to be
yeah,
careful
yeah,
about
yeah.
too much energy.
Well, I
yeah.
said just yes or no. I didn't even get that out of it. So be it.
And I didn't ask a question. We'll have to do it another time about the difference between the ceramic printable materials, but that's for another.
That's on top of the actual light attenuation. Yes, we'll get to those ones in the future as well. So to those that are listening in, and as you can tell, we're three nerds when it comes to this kind of stuff, that we really get a lot out of knowing what it is that we're utilizing, what we're using. And I think that's honestly why it is for Dental Advisor that we love being a part of this, because we like to see how things evaluate. We like to see how materials are developing. We like to try things out for ourselves. We like to know that as we do go through these different materials and these different companies and projects, that what we're actually offering up is some valuable information for those that are looking us up. So if you're looking for different ideas, different values, different things like that, then go to the website, www.dentaladvisor.com. And as we've said, you're looking at 3 clinical ambassadors right now that we really do get involved with this kind of stuff. And it's going to be much, much more available to the public here very soon with different things that Dental Advisor is doing. So kind of stay tuned to what's coming up. For us, if we kept Taiseer going, I mean, we'd be another couple hours.
Yeah,
So,
no kidding.
all of us from Dental Advisor, Dr. Paresh, Dr. Taiseer, I am honored to have you guys with us tonight. But overall,
Thanks, Ashton.
thanks for your
Appreciate it.
time, guys.
Thanks,
And for those that are
Taiseer.
listening in, we'll
Always
see you
a
at the next
pleasure, gentlemen.
podcast time with the
got
Disruptive
it.
Dental Science podcast. We'll see you guys next time.
It's great.
Thank you.
Thank
guys.
you.